Well, I should address the failing left ventricle, and I have to admit, when Felix invited me to give this talk, I started to argue with him. First of all, I said, why don't you pick one of these many heart failure experts we have in adult cardiology, because this has become really a big business. But he said, well, he prefers to have a simple-minded congenital and valvular heart disease cardiologist for this talk. And the second reason why I started to argue with him was that I said, is this really a big issue for us? I mean, aren't we mainly struggling with the failing right ventricle, the failing systemic right ventricle, the failing univentricular heart? And how important is left ventricular failure in adult congenital heart disease? Now, this will be the first question I would like to address. The second is, are there even for the left ventricle differences between left ventricular failure in congenital and acquired heart disease? Can we really use all the recommendations we have from acquired heart disease? How important is heart failure with preserved left ventricular ejection fraction for us? And of course, one of the purposes was that I was supposed to say something about the main principles of the recent EC guidelines for treatment of left ventricular failure. Now, when I tried to find out how frequently we deal with left ventricular failure, just from my feeling, I said this is not a big issue for us. But I didn't find any data. I hope I looked carefully enough. Actually, the only paper I found is a very recent paper coming from the Dutch Concor registry, where they looked at the frequency of heart failure admissions in these more than 10,000 adults with a median age of 37 years. And they reported that there was a rate of 2.5% of first heart failure admissions over a median follow-up of 21 years. So this is consistent with an incidence of first heart failure admissions of 1.2 per 1,000 patient years. Doesn't sound much, but is 12-fold what you would expect from the general population of adults in the same age category. And of course, heart failure is much more frequent than admissions in this population. The median age at the first admission was 47 years, and these patients afterwards had a 5-fold higher risk of mortality. Now, why I looked at this study was because they tried to find risk factors that predict heart failure admissions. And the patients at higher risk were those with multiple defects, were patients who had surgery during adult childhood, or had reoperation during childhood, or had received a pacemaker implantation during childhood. And then, of course, there were differences between the defects, and it's not surprising. The patients who were at the highest risk to develop heart failure and be admitted for heart failure treatment were those with univentricular hearts, with transposition of the great arteries, with tetralogy of Fallot. These had the highest risk. But there were also patients with aortic stenosis, patients with AVSDs, patients with pacemakers, and of these, many may have had left heart failure. Looking at the absolute numbers of patients they collected, again, the majority of them apparently had right heart problems. Atrial septal defect, tetralogy, pulmonary stenosis, transposition, Epstein's, pulmonary atresia, univentricular hearts. And a minority, but still a significant number, had apparently left heart problems, aortic coarctation, aortic stenosis, bicuspid aortic valve, Marfan syndrome. And some of these patients with shunts may have had left ventricular failure. There may also be patients with pulmonary hypertension and right heart failure. So that we can only guess, apparently, at least 15% of these patients, so it's the minority, but still a significant number, had a failing left ventricle. Maybe it goes up to almost 30%. Now, more frequently than patients who are really admitted with heart failure, we may see patients who are still asymptomatic and have reduced left ventricular function. This is an example of a 44-year-old man. He had VSD and aortic valve repair at an age of 6 and presents now with a mildly reduced left ventricular ejection fraction. I'm sorry, I actually tried to find a patient where it's more obvious that there is some reduced left ventricular function, but we see these patients with an ejection fraction of 40, 45, or even a little bit less, no hemodynamic problems. Should we treat them? Now, we know from acquired heart disease that even the asymptomatic patients with left ventricular dysfunction benefit from ACE inhibitors and beta blockers. And it has been shown that they can effectively reduce the number of heart failure admissions and death. This is mainly from the SOLVED prevention trial, where more than 4,000 patients were randomized. And in this trial, there was a 20% relative risk reduction in death and heart failure hospitalizations for those treated with ACE inhibitors. And there's also been shown that there's a synergistic effect of enalapril and beta blockers. And this is the reason why in the guidelines we will see that even the patients who end up in New York Heart Association class 1, we continue to treat them with ACE inhibitors and beta blockers. Is this really applicable to young congenital heart disease patients with some residual asymptomatic LV dysfunction who are stable over years with that? We don't know, and I think this is questionable. Now, this is probably the easiest situation. This is a young man, 26 years. He had VSD and coarctation repair at an age of 1 year. And now he presents without any residual problems. There was no residual shunt from his VSD. There was no residual significant obstruction of the coarctation, even no hypertension. But he presents with reduced left ventricular ejection fraction, 29%. I show the MRI because the quality of the echo was not that good. And he presents in New York Heart Association class 3. Now, I think everybody would say in this situation we can simply refer to what we know from adults with heart failure and go to the EC guidelines and treat the patients as according to these guidelines. And there we have 60 pages of recommendations, and many of them with a very high level of evidence, many class 1 indications, and many of them are class 1 with a level of evidence A, and this means in ESC recommendations that this recommendation is based on multiple randomized trials, on meta-analysis, and many of them are evidence level B, and this means that there's at least one randomized clinical trial and large prospective non-randomized studies. So apparently, these guidelines are based on a high number of randomized trials, including many thousands of patients. We have already heard about that. But can we apply these recommendations to congenital heart disease patients? And we have to admit that in these randomized trials, hardly, if at all, congenital heart disease patients were included. There were some, but certainly a minority, who had valvular heart disease, so apparently in a similar situation. Maybe we can use hypertension as a model of long-lasting pressure overload, at least for those patients with congenital or valvular heart disease who have primarily pressure overload. But on the other hand, if we look what has been studied in acquired disease, that the most concern was always that there's a difference if this is ischemic or non-ischemic, and there are a lot of studies that actually looked at that. And when we take the guidelines as they are, we can say after all these studies, as soon as heart failure syndrome, when the left ventricle is the failing ventricle develops, there appears to be no difference in the basic treatment concepts that we need to use, and we don't need to make any differences, at least when we follow these guidelines. Of course, if there is comorbidity in the sense of ischemia, hypertension, arrhythmias, this will influence the choice of medication we will use. Now, what I would also like to stress is which are the patients studied here and to whom are the recommendations made. And apparently, heart failure is really clinically defined. Heart failure is defined as a syndrome. These are the patients who present with typical symptoms such as breathlessness, ankle swelling, fatigue, and with typical signs such as elevated jugular venous pressure, pulmonary coagulation, and displaced apex speed, resulting from an abnormality of cardiac structure or function. Opposed to a more pathophysiologic definition of heart failure, that this is an abnormality of cardiac structure or function leading to failure of the heart to deliver oxygen at a rate commensurate with the requirements of metabolizing tissues despite normal filling pressures or only at expense of increased filling pressure. So this is the clinical definition that counts here. And obviously, the heart failure syndrome can be caused by myocardial disease causing systolic dysfunction, but very importantly, it can also be the diastolic dysfunction, and this may, particularly in our patients, be the even more important population. On the other hand, most of the studies available for heart failure refer to patients with reduced ejection fraction, and most of them actually an ejection fraction less than 35%. And this is now called heart failure with reduced ejection fraction. So these patients need to have an ejection fraction less than 35 to 40% with the symptom as I have defined it. Now, on the other hand, when we look at the studies, in some even half or more of the patients have heart failure with preserved ejection fraction. This is defined as an ejection fraction greater than 40 to 45. So this means that in this population, there is still a number of patients who have actually some reduction of ejection fraction, but only mildly reduced ejection fraction. And this is also referred to as diastolic heart failure, but we'll come back to that. There's still a controversy how much diastolic problem is here really in the first point. Now, heart failure with preserved ejection fraction, as I said, appears of an even greater interest for us in adult congenital heart disease, but when we look at the recommendations of these 60 pages, only 1/2 page refers to heart failure treatment in the population with preserved ejection fraction. And that's what the guidelines say. We can use diuretics to control sodium and water retention, and obviously can relieve breathlessness and edema to some degree with diuretics. That's not surprising. Adequate treatment of hypertension and ischemia, where it's present, is important. Rhythm and heart rate control. Apparently, this refers to the atrial fibrillation patients. And although there's only two very small studies, it's mentioned that verapamil may improve exercise capacity and symptoms in this population, and beta blockers may be used for heart rate control. And this does not mean that we don't have any studies looking at this population. If you look at the summary of studies, it's about 10,000 patients who have so far been studied with candesartan, with perindopril, with irbesartan, with beta blockers, and none of these studies could show any reduction in mortality or heart failure hospitalization as a combined endpoint for this population. There's even a discussion how should we really define this entity and how do we correctly diagnose it, because it's more difficult to diagnose heart failure with preserved ejection fraction than heart failure with reduced ejection fraction. And this is the definition in the guidelines. The patients have, again, the typical symptoms, but now in the group where we are dealing with normal or only mildly reduced EF and normal-sized left ventricles, is even more important to exclude other causes for these symptoms, such as anemia or lung disease. Then they should have the typical signs of heart failure, but it's already mentioned here that they may often not be present, particularly in the population with preserved ejection fraction. These are early stages. They may have only symptoms on exercise, and when the patients are treated with diuretics, the signs are also gone. So we are left with this important point that they should have some structural heart disease, mainly left ventricular hypertrophy, enlargement of the left atrium, and or diastolic dysfunction. Now, the definition of diastolic dysfunction in clinical practice is also still a matter of controversy, and the most important information can probably be derived from mitral inflow and mitral annulus velocity, and at least in clinical recommendations, the definition mostly refers to this ratio of E to E prime, E the peak velocity of mitral inflow, and E prime the peak early velocity of the mitral annulus. And if this ratio is less than 8, it's very likely that the patient has a normal filling pressure. If this ratio is greater than 15, it's very likely that the patient has a diastolic dysfunction with an elevated filling pressure. And the E prime less than 9 centimeters per second on average defines a delayed relaxation. There's still the discussion whether really the diastolic dysfunction is the problem in these patients, or whether this is more or less a problem that ejection fraction is not good to define left ventricular systolic function. And the Paramount trial actually addressed this and showed that most of these patients who were classified as diastolic heart failure actually had a reduced systolic longitudinal function, and we need more sensitive techniques such as speckle tracking, strain analysis, etc., to define that. So even for the pathophysiology and for the definition of these patients, there's some controversy. Now, there's ongoing research, of course, how we can treat these patients. There are ongoing studies with verapamil because these small studies are not really conclusive. There is a more hypothesis-generating study on statins. Iraputin, we have a minority of patients included in the senior trial, but this is a drug of interest that will be continue to be studied for preserved ejection fraction heart failure. Sildenafil has been studied in the RELAX trial, but the result was negative. And there's a lot of interest in aldosterone antagonists. And the reason is that you're probably all aware of these large studies that clearly showed survival benefit for patients treated with spironolactone or eplerenone. One study, they will study this in severe heart failure with reduced ejection fraction. The emphasis study, mild heart failure with reduced ejection fraction, risk reductions 22%, 22% and 30% in these two studies. Now, so far, there was only this one smaller trial, the ALDO-DHF trial, showing an improvement in diastolic function, looking at E to E prime and a reduction in NT-proBNP. However, this study could show no improvement in exercise capacity for the patients. And so this top cut trial was awaited anxiously, and I showed the results because they have just recently been presented at the American Heart Association. Again, a very large trial, including more than 3,000 patients. Two-thirds of them had New York Heart Association class 2, and one-third of them had New York Heart Association class 3. And most of them were hypertensive. Two-thirds in both groups had coronary artery disease. So this is the population. The majority of them, probably more because they had hypertension than that this was seen as a heart failure treatment, were already on AC inhibitors or angiotensin receptor blockers, more than 80%, and on beta blockers. Now, this study defined as the primary endpoint the combination of cardiovascular death, of heart failure hospitalization, and resuscitation, and it was negative. More than 3,000 patients, follow-up 3.3 years. The mean dosage was 25 milligrams, and the result was there was no benefit of spironolactone. There's a mild difference between these two curves, and this is mainly driven by the difference in heart failure admissions. And just looking at hospitalization for heart failure, the result was actually significant. And if you look at the numbers, 14% versus 12%, so it's a small but still significant relative risk reduction, again, of 15%. It's always important these are all relative risk reductions reported for these guidelines, and the clinical relevance is another matter to look at. And this was at the expense of hyperkalemia in many patients. About 1/5 of the patients developed hyperkalemia, and frequently there was an increase in creatinine, although these patients had this relatively low dosage of spironolactone. So again, I think we need to wait for better drugs, and heart failure with preserved ejection fraction is actually still a problem that's not solved. Now, this was the first half page. Now come the 59.5 pages for the left ventricular failure with reduced ejection fraction, but don't be afraid. I will finish in 2 or 3 minutes. I just try to summarize now the part for the reduced ejection fraction, because this is really the easier part, and this is really on solid ground. So it's clear, I've already mentioned it, that all patients are on EC inhibitors and beta blockers. If they don't tolerate an EC inhibitor, they get an angiotensin receptor blocker, and they stay on that even if they end up in New York Heart Association class 1. Now, if they are still in class 2 or higher, we will add an aldosterone antagonist as the next step. And as I said, all these recommendations are class 1, level A, because we have so many studies here. The cutoffs are 40% for the ejection fraction for ACE inhibitors and beta blockers. And this evidence, class 1, level A, refers to less than 35 ejection fraction for the MRAs. And as I said, thousands of patients, relative risk reductions in death for the ACE inhibitors, somewhere between 16 and 27%. For the beta blockers, relative risk reduction in death, 34% within 1 year, in a similar range for heart failure hospitalizations, and an added effect of MRAs, again, about 30% for death and 35% for heart failure admissions over 2 years. So this is really on solid ground. This is really evidence-based therapy. Now, if the patients are still in New York Heart Association class 2 or more and have an ejection fraction less than 35 and have sinus rhythm with a heart rate greater than 70 beats per minute, they should get ibuprofen. This is a new recommendation of the 2012 guidelines based on new studies. Now, if the patient is still symptomatic and has QRS duration greater than 120 milliseconds, we need to consider a CRT. At this point, we also need to consider an ICD. And only after all that, you see, comes digoxin and vasodilators, of course, then finally at the end stage, LVAD and transplantation need to be considered. Now, for the angiotensin receptor blocker, it's a class 1A that we should use them, as I've already said, when the patients do not tolerate an AC inhibitor as an alternative. If the patient does not tolerate an MRA and has already AC inhibitor and has beta blocker, it's also a class 1A to add an angiotensin receptor blocker. Now, for ibuprofen, less studies. You see this is only level B and a 2A recommendation to add this. And for everything else, digoxin, for vasodilators, very weak recommendations, only 2B recommendations. So we add this when everything else has not worked. And finally, for the CRT, it's a little bit more complicated, but it just mentioned these key messages that for those patients who are in New York Heart Association class 2 or more and are in sinus rhythm and they have an ejection fraction less than 30%, and a left bundle branch block with 130 or more milliseconds, it's a class 1A recommendation now to implant a CRT. For the patients who have another morphology of their QS duration prolongation, but is more than 150 milliseconds, it's a 2A recommendation to consider the CRT. So at the end, I just would like to give you the follow-up of the 2 patients I have started with. This first patient with the mildly reduced ejection fraction has a follow-up of 5 years. He had so far no therapy, but LV ejection fraction did not change. He's still asymptomatic. The second patient was started on standard left ventricular heart failure therapy and is, after 2 years in a New York Heart Association class 1, the NT-proBNP has almost normalized, and I show here the echoes now, although the quality is worse than the MRI, but we didn't repeat the MRI. And I think even from these echoes, you would agree that the ejection fraction has also improved in this patient. So to summarize, I think failure of the left ventricle is certainly not the main concern we have in congenital heart disease. But what we can say that for some patients it's indeed important, and we're in a much better situation than for the problems of the right ventricle and the univentricular heart. We can use what we know from acquired heart failure. The problem is that for preserved ejection fraction heart failure, we have very little information and need better therapy in the future. Thank you for your attention.